A 28-year-old female presents with high spiking fevers, pleuritic chest pain, and hemoptysis. I am showing you a frontal chest radiograph and an axial chest CT scan. Describe the findings.
The chest radiograph demonstrates multiple bilateral, poorly defined nodular opacities, predominantly in the lower lung zones. The axial chest CT scan confirms multiple peripheral, bilateral, basilar predominant nodules. Several of these nodules show thick-walled cavitation, and there are also wedge-shaped peripheral consolidations abutting the pleura. A pulmonary vascular branch is seen directly entering one of the cavitating nodules, representing the vessel sign.
Based on these imaging findings, what is your primary diagnosis and the key diagnostic sign?
The primary diagnosis is septic pulmonary emboli with secondary septic infarctions. The key diagnostic sign is the feeding vessel sign, or vessel sign, which is highly characteristic of septic emboli.
If I tell you the patient has a history of intravenous drug abuse and a central venous catheter in place, how does this clinical history support and explain the diagnosis?
This clinical history strongly supports the diagnosis. Intravenous drug abuse and indwelling central catheters are classic risk sources for right-sided infective endocarditis or septic thrombophlebitis, which shower septic emboli into the pulmonary circulation.
What organism is most commonly isolated in septic pulmonary emboli in this patient population?
Staphylococcus aureus, particularly methicillin-resistant Staphylococcus aureus, or MRSA, is the most common pathogen.
Name 2 other types of infections that can cause rapidly growing nodules in non-AIDS immunocompromised patients.
The 2 types of infections are angioinvasive fungal infections, such as aspergillosis or mucormycosis, and septic emboli.
What are the 2 most common sources of septic emboli?
The 2 most common sources are tricuspid valve endocarditis and infected indwelling venous catheters or pacemaker wires.
Explain the pathophysiology and appearance of the wedge-shaped consolidations seen on CT.
The wedge-shaped consolidations represent pulmonary infarctions. Because pulmonary arteries are endarteries, occlusion by septic emboli causes necrosis of the downstream peripheral lung tissue, which abuts the pleura in a triangular or wedge-shaped configuration.
What is Lemierre syndrome and how does it relate to these findings?
Lemierre syndrome is internal jugular vein septic thrombophlebitis, classically caused by Fusobacterium necrophorum following pharyngeal infection. It is a well-known source of septic pulmonary emboli, presenting as bilateral cavitating nodules.
State the critical safety warnings and potential cardiac complications of right-sided endocarditis.
The critical safety warnings are acute tricuspid valvular destruction, leading to severe tricuspid regurgitation and right ventricular failure. There is also a risk of septic shock and systemic embolization if a patent foramen ovale is present.
What are the immediate clinical management recommendations for this patient?
I would recommend obtaining urgent transthoracic and transesophageal echocardiography to evaluate the tricuspid valve, initiating immediate broad-spectrum intravenous antibiotics such as vancomycin, obtaining blood cultures, removing any indwelling central catheters, and referring to cardiology and infectious diseases.